surgery. I'm not going to ask him to cut sutures. He's, you know, he's there just to keep you company, see the baby. All right? Done in the operating room. Who's going to be there? I have an assistant. The assistant is often a family doctor who will come in, who's on for that day. Sometimes it's another obstetrician. There may or may not be a pediatrician depending on the risk level. In some hospitals, pediatrician's always there. We would like for them to be there, but they're not always there. If there's a risk, pediatrician will be there. Okay, anesthetist, a couple of nurses. One person in the operating room with you. Okay, in the delivery room, you can have two people. You can have your husband, you can have your sister, or your mom, a friend, whatever you want. But in the operating room, one person. The cesarean section takes about half an hour, sometimes a little bit longer, depending on technical reasons. Okay, if I've got somebody who's really big, it might be a little more, there are various things that might make it a little more difficult. But usually, about a half an hour from the time that I start to the time that I finish. The incision we make varies. Most of the time, I'll make an incision that's down here, a little vanity incision. Okay, we'll shave you down and do a little incision in the hairline. Sometimes I'll go up and down. And that will depend on various things. Scarring, previous incision, previous cesarean section, position of baby. Various things will entice me to do it this way. Now, this incision is a vanity incision. It's easy the first time. The second time, it's harder because of scarring. The third time, it's hard. And by the time you do this 4 times, it is vicious, the amount of cement that's in there to try and cut through. This incision is easy all the time. And this one I can make as big as I need. This one I've only got so much room. This incision can be extended. So which one's a safer incision? This one's safer. In the long run, this one's prettier. We'll talk about the incision that we're going to make, but most of the time it's going to be this way. Okay? Fair? About 30 minutes or so. The upside to the cesarean section is the vagina gets preserved. That's a big upside. The downside is it's an operation. And an operation comes with all its risks. The risks of blood loss, the risks of infection, and long-term risks, adhesions, scar tissue, and the likelihood that you're going to end up with another cesarean. If you've had a cesarean section, does it mean that you're always going to have a section? Once a section, always a section. The answer is yes and no. Because it comes with a risk. And the risk is this. If you've had a lower segment incision, okay, upper segment, lower segment, a transverse incision, and the operation is called a lower segment transverse cesarean section. Okay? The incision in the skin and muscle may be up and down, but the incision in the uterus is almost always this way. Very rarely would I make an up and down incision. And that would happen only if we've got huge blood vessels or a placenta that's sitting there, or a transverse lie with the back down. There are certain circumstances under which you're going to make an up and down incision. Most of the time, it's going to be this way. I would say this way 99.9% of the time. Very few times do you need to go up and down. So a lower segment transverse cesarean section. Even so, that incision has about a 1 to 2% risk of rupturing in labor. This incision has a much higher risk of rupturing in labor. Some people say 5%, could be even higher. Don't know. Don't see it very often. So I don't know. What's my experience with repeat, vertical incisions in the uterus? The answer is it's extremely small because I don't make those incisions. This incision has a small risk of rupture. Having said that, will I allow somebody who's had a previous cesarean section to labor? And the answer is, it depends. And it depends on a number of factors. It depends on what the reason for the first cesarean section was. If the first cesarean section was for disproportion, you just didn't have enough room, what makes you think you're going to have any more room the second time? Okay? So if the first one was done for disproportion, you're going to have a repeat cesarean section. But if it was done for a non-recurrent problem, so for instance, the first time you had a breech, and now your baby's head first, could we allow you to? Sure. You might want to. You might, on the other hand, say, you know what, I was okay with the cesarean section, just do a repeat. And that's what mostly happens. Or if the first cesarean section was done because the heart rate was terrible, and now the heart rate's perfect, could we let you labor? And the answer is sure. As long as we see good progress, the head is nicely down, and again, I want to keep it safe. So that means I really would like it to be during the daytime, when all the nurses are around and the anesthetists. I really don't want a girl who's had a VBAC, who's having a repeat cesarean section, who's having a vaginal birth after a section, a VBAC. I don't want her in labor, 2 centimeters dilated, Sunday morning. I'm uncomfortable with that. And I would say to her, you know what, let's do the safe thing, and let's have a cesarean section. But on the other hand, if she comes in and she's 5 centimeters dilated, and the head is nicely down, and she's making good progress, and she's accepting this, and I say, you know what, the risk is 1% of rupturing. Are you okay with this? What do you want to do? And she says, I want to try. I'll say, okay. Is that fair? So it's going to depend on different situations as to how we're going to deal with this. All right? The downside to the cesarean section is you don't get the baby. He gets the baby. In a normal delivery, you push the baby out, or we help you a little bit, and the baby comes out, and I put the baby up on your tummy, and we look at it, right? We take pictures, right? And we look at the baby together. It's a boy, it's a girl, it's this, it's that, everything is okay, right? And we clamp the cord and cut it, and we give it to you. It's your baby. You can hold the baby, you can cuddle with it right away. Cesarean section, he gets to cuddle with it right away, you don't. I'm sorry. Yes?
When you say the uterus rupturing after a first cesarean section, what do you mean by that when it ruptures? The uterus or the
scar tears. The scar actually tears. Sometimes, listen, I've done cesarean sections, repeat cesarean sections, and they're booked cesarean sections. It's booked. She's not in labor. And we do the surgery, and I look at the uterus and I say, oh my God, that uterus is so thin, I can see the baby through it. That uterus probably, it's what's called an occult rupture. It hasn't ruptured, but oh my God, it's as close to rupturing as you can get. And you say, you know, I'm glad we did this today and not tomorrow. And then sometimes we'll do a cesarean section for someone who's had a previous cesarean, and we take the bladder down, and the uterus is just that thin. That scar is the weakest part. And if it ruptures, the baby will come out through the scar. And if it comes out through the scar, and it's still inside you, we haven't operated on you, the baby will probably die. It is highly unlikely that we're going to get to operate on you and save the baby's life. It will die. Now, when it tears, it could tear anywhere. And if there's a lot of bleeding, the next consequence number 1 is the baby dies. Consequence number 2 is we need to take the uterus out. She ends up with a hysterectomy because of bleeding and just where it's gone, and we can't save the uterus. Consequence number 3, if this happened at home, is the mother dies too. Does that happen? Mercifully, not here. I've never seen it. I've never heard of it. Have I seen ruptured uteruses? Yes. With bad consequences? Yes. Do we want to see them again? No. Am I going to see it again at some stage in the future? Probably, because it's the nature of medicine. But that's a bad outcome. Any way you describe it, that's a bad outcome, right? So, is the risk a big risk? No, the risk, having said that, is still a small risk. It's a 1 to 2% risk of rupturing, but the consequences of it rupturing are catastrophic. Does that answer your question?
Yeah.
Okay. In an ordinary delivery, vaginal delivery, we're in the delivery room, baby's delivered, we look at the baby, I give it to you, we make sure that everything's okay, and we suction the baby out. As soon as the baby's head comes out, the very first thing I'm going to do is suction the baby's nose and mouth, because the very first thing it's going to do is, so whatever's in there, I want to suck it out. We deliver the baby, give it to you, clamp the cord, and the baby goes over into a warmer. Okay? There's a warmer in the room. And we're going to give the baby a score. Baby's going to get a score from 1 to 10. It's called an APGAR score. It's named after an American anesthetist by the name of Virginia Apgar, who developed this score a long time ago. And the score is from 0 to 10. 0 is bad, and 10 is perfect. Very few babies get a 10. Most babies are going to get 7, 8, 9. And we want to be as close to 9 or 10 as we can. And you're going to be able to score the baby yourself, because here's what the baby's score is based on. 5 individual items for which the baby gets a score of 0, 1, or 2. 5 times 2 is 10, 5 times 0 is 0. Number 1, heart rate. Baby's got a heart rate of 100 or more. Baby gets 2. Baby has a heart rate anywhere from 1 to 99, gets 1. No heart rate, gets a 0. Breathing. Baby's breathing away. 2 points. Baby makes 1 attempt to breathe. Doesn't breathe again. 1 point. Doesn't make any attempt to breathe at all. It is totally flat. No attempt to breathe. 0. Color. Baby's nice and pink all over. 2 points. Baby's nice and pink, but the hands and the feet and the tongue are a little bit blue. 1 point. Baby's blue all over. 0. Now, almost all babies are going to lose a point for color. Okay? If they're going to lose a point, they're going to lose 1. They're almost always going to lose it for color. And the reason for that is because the hands and the feet and the tongue are farthest away from the heart. And remember that when the baby is inside you, there are little shunts, holes in the heart, that allow blood to mix from both sides. Remember, the lungs inside are collapsed. The baby does not breathe inside you. The lungs are collapsed and almost no blood goes to the lungs. The very first thing that the baby does when it comes out is it takes a breath. And all of a sudden, these lungs, which have never been used, magic, they open up, and all of a sudden, the oxygen and carbon dioxide get transferred. It's amazing. And then with the next breath, they open a little more in the next breath, and that's taken 3 seconds. How long? That took 1 second. Amazing how the lungs open up. But the holes have to still close. And these shunts take time to close. And sometimes they close within minutes, 5 to 10 minutes. Sometimes they take hours, and once in a while, they don't close at all. And the longer they stay open, the more blood can mix from the right side to the left side, and the bluer the baby is. Right? So if we see a baby that looks off color, it's not oxygenating properly, we need to sort out whether this is a breathing problem, a lung problem, or whether this is a cardiac problem, or a combined problem. Okay? So baby's going to lose a point for color. Tone. The baby's nice and stiff. Right? You pull on the arms and there's rigidity. 2 points. You pull on the arms and there's a little bit of rigidity. 1 point. And if it's lying there like overcooked pasta, gets a 0. And it's probably not breathing, and it might be blue, and the heart rate might be right. Everything is tied together. So if you've got a baby that's screaming, it's already got 2 points for breathing. It's for sure got 2 points for heart rate. And its tone is like stiff like this. This baby's already got 6, 7, 8, right? And the last thing is reflex irritability. I come up to the baby and I flick it. We don't smack them anymore, right? We don't toss them up in the air and catch them. We give it a little flick like this. There's the baby's foot, and we give it a little flick, and it responds. 2 points. If I flick it like this and it grabs my arm and says, "What do you want?" gets 2 and a bonus. All right. So if we flick it, it gets 2 points. If I flick it like this and it responds a little bit, it gets a point. And if it just doesn't care about me at all, it gets a 0. All right? So you're going to be able to score your baby by yourself, because you're going to see that baby over there. It is screaming away. It's nice and pink. What are we going to take away from that baby? Maybe a point for color? Right? So you'll be able to score your own baby. And we score the baby twice. Once at 1 minute. And 1 minute is a long time from the time that baby is born to 1 minute is really quite a long time. 60 seconds is a long time. And then we score the baby again at 5 minutes. The 1 minute APGAR is not nearly as important as the 5 minute APGAR, because the 1 minute APGAR can be affected by the vacuum and forceps and how difficult the delivery was and all kinds of stuff. The 5 minute APGAR should be a good score. That is a long-term predictor. If you see a baby that's got an APGAR of 9 at 5 minutes, that baby should do just fine. But if that baby's got an APGAR of 3 or 4 at 5 minutes, and none of us are paying any attention to you, and we've called the pediatrician, called the anesthetist, and we're all over here working on the baby, there's a concern. Is that fair? You understand that. So you're going to be able to score your own baby. Now, something magic is going to take place in the delivery room. He's sitting right beside you at the time of the delivery. He's right up at the head of the table, and the baby comes out, and now we put the baby over in the warmer. And all of a sudden, he disappears. He's over here now with the baby, and you're going to see his butt for the next half an hour, right? Because he's got a new buddy, right? He's over here with the baby, and you chopped liver now, right? He wants to cuddle with the baby, he wants to play with it, he's given it a name already. He wants to wrap up the baby, and he wants to take it out and show his mom, right? Look, Mom, look what I did, right? Look, Mom. Because the family's out there, right? Everybody's here. He just wants to go show his mom. That's what happens. Guys, bring a camera, take pictures. If you want to bring a video, you can bring a camera. You can bring a video camera. You can video the baby. They don't let you video the delivery. I think it's for who are you going to show it to? And I think it's for medical legal reasons anyway. But if you want to, after the baby's delivered, video the baby. Take as many pictures as you like. If you take pictures of me, you need to send me a copy. That's the deal. All right? Now, for those of you that are going to be interested in the cord blood program, remember we talked about that last day? As soon as the baby's delivered, I'm going to clamp the cord, and I'm going to take as much blood from the cord as I can for the cord blood program. Now, maybe there's a little bit of controversy. Some people say deliver the baby and don't clamp the cord. Leave it for as long as possible until it stops pulsating, and just leave it. Honestly and truly, I've never seen it make any difference one way or the other. Okay? I've never seen it make any difference one way or the other as to whether you wait 3 minutes to clamp the cord or you wait 10 seconds. So what do? I deliver the baby, and then I clamp the cord, right? And then I put the baby over in the warmer, or I give it to you, depending. I mean, if the baby's perfectly okay, it's screaming, and you want to hold the baby, it's right there on you. We'll put a blanket over you, keep the baby warm, and we'll give you the baby right away. Fair? Okay. Now, everybody's happy now, right? Is it over? No. It's not even close to over. Because the next thing I've got to do is I need to deliver a placenta. Okay? Remember I said baby, cord, and placenta are all baby. And the cord and the placenta need to come out too. Most of the time, it's not an issue. Within a minute or less, remember I said a minute's a long time, the placenta's out. The uterus contracts down. We put a little traction on the cord, make sure the uterus is well contracted, and the placenta will come out. Almost always, it's out pretty quickly. We give you some oxytocin after the delivery. It helps the uterus to contract down. If it's given too soon, sometimes it can trap the placenta. We try to time it properly, and the placenta comes out. Okay, cord, placenta are out, and we make sure that it's complete, that as best we can, to make sure there are no parts left inside. A little piece of placenta once in a while. If I'm not certain, I'll examine you. I'll put my hand up inside the uterus, make sure the uterus is empty. Right? At the time of cesarean, you got a chance yesterday to put your hand up inside and feel how empty the uterus is. Make sure that everything is out. Placenta is delivered. Once in a while, placenta doesn't come out, and the uterus contracts down and traps it. Okay, I need to pull my glove up to here and put my hand up inside and go fish out that placenta. And that uterus contracts down really quite rapidly. And sometimes it traps the placenta in there. And I've got to get my hand, this hand, up inside the vagina. Now, if you see a guy with a penis this big, run! If you've had an epidural, I can do this. I can put my hand up inside and you'll be comfortable. If you have not had an epidural and I need to go fish out the placenta, you're going to remember this, I think, forever. It's uncomfortable. I don't want to tell you that it's not. But if you've had an epidural, all right, it's going to be a little uncomfortable, it might be, but it's going to be tolerable, and I'm going to be able to reach up inside and get my fingers inside the uterus and deliver the placenta. We need to get the placenta out. If the placenta doesn't come out, you will bleed. The uterus will not be able to contract down properly, and you may hemorrhage. I don't want that to happen. We need the placenta to come out.
So realistically, it's a simple thing if everything works out well, but if it doesn't, you actually have to, how do you do it? You actually, it's being forced out? Is that what happens?
I'm going up to grab it.
Yeah,
I'm putting my hand up, I'm supporting the uterus with this hand, and with this hand I'm going up inside the vagina, inside the uterus, and peeling the placenta off and getting it out. Sometimes you lose sensation. I mean, it's not always easy. And once in a while, you can't get it. Now, you could sit back and wait. You could sit back and wait. The uterus is contracted down. It's trapped. You could say, okay, I'm just going to wait. It'll come out. What if it doesn't? And how long are you prepared to wait? Most of the time, we don't do that. Most of the time, we actively manage that stage of the delivery. We actually go up and get it. Some people will be a little more passive and wait for it to come out. I'm aggressive. I usually go and get that placenta. And once in a while, a placenta is so adherent that it doesn't come out. And now we have a situation. Now you've got what's called a placenta accreta, where the placenta has actually grown into the muscle of the uterus. And that's a dangerous situation. Okay? And there's some controversy about how to treat it. But the classic and old school teaching for a placenta accreta, if you've got a placenta that doesn't come out and you can't get it out because it's grown into the uterus, is you take the uterus out. Now, if this is a girl who's had her first baby, doing a hysterectomy is a tragedy. If it's her third or fourth baby, she'll probably kiss you afterwards. Thank you for getting rid of it. I don't have to do this again. On the other hand, doing a hysterectomy in a postpartum uterus, it's complicated. We don't do it very often. Okay? We don't do it very often, mercifully. I think I've done it maybe twice in my life, that I've had to take a uterus out after a delivery. So in 30 years, 15,000 deliveries, to do it twice, I think that's reasonable, 1 in every 7,000 deliveries, you know. But does it happen? And, you know, the risk increases with the number of cesarean sections. The risk of having a placenta that's grown into the that's grown into the muscle of the uterus increases with the number of cesarean sections that you've had. Because it sticks to the scar. It just sticks to that scar area. What were you going to ask?
With the placenta, taking the placenta out, you showed us earlier that it tears easily. How do you make sure that you get it all?
You have to feel it.
What happens if, let's say, a little piece stays in or something like that?
Can that happen once in a while? Yes. And what happens often is that 2 days later, a little piece comes out.
Okay.
It comes out by itself, and once in a while it doesn't. And she may come back to the hospital bleeding. And then we may need to do a D&C to take it out. Comes back with persistent bleeding or a postpartum hemorrhage, and we may do an ultrasound. It may show something.
Routine D&C procedure?
No, it's not routine.
Yeah.
We don't do very many postpartum D&Cs.
Sure.
Not very often. But sometimes there can be significant bleeding. And once in a while, somebody has a postpartum hemorrhage. The uterus just doesn't contract down. We give them oxytocin, and for whatever reason, it just doesn't contract. And remember I said, a lot of blood goes to the uterus. 30% of the cardiac output is going to the uterus, and you can lose an enormous amount of blood very quickly. So postpartum hemorrhage is a serious problem. Mercifully, not very often, but when it happens big time, and you need to act quickly. Contract that uterus down, make sure that it's contracted, put up 2 IVs, arrange for blood, transfuse her, get ahead of the game, right? If I see that somebody's losing blood quickly, you know, I want to get on it as fast as I possibly can. I'm not going to stall, right? And I'm going to transfuse. I don't transfuse very often. But do we transfuse? Yes, absolutely. My wife had a transfusion after the last baby. Okay? Yes?
So we discussed so many negative things about the cesarean. Why would somebody request it?
Why does somebody want to have a cesarean section? You know what? Everybody has a different idea in their head. Some people are just terrified. I have some people who are absolutely terrified to go into labor. Terrified. Some people have had previous surgery and don't want to disturb the surgery. People have a million different reasons for why they want to have a cesarean section. Having said that, I don't want to make it so negative. You know, most of the time, the vast majority of time when we do a cesarean section, there are no consequences. It's an operation. And she ends up with a scar. And that's the sum total of the consequence. Instead of being in hospital for 2 days, you're in hospital for 3 or 4 days. Instead of getting the baby right now, you're going to get the baby 6 hours later. Because after the cesarean section, you're going to go to the recovery room, the baby's going to go to the nursery, and then you're going to go to your room, and when the freezing has worn off, right, spinal or epidural, and you're relatively comfortable, they're going to bring you the baby. So instead of getting the baby right now and being able to, if you want to, nurse right now, you're going to get the baby 6 hours later. And is it going to hurt more? Yes. Is the recovery from a cesarean section slower than for a vaginal delivery? I think as a general statement, I think the answer is yes. But having said that, those girls who walk into my office a week later, having had a cesarean section and they're there for stitch removal, for clip removal, you don't see any of them walking in like this. They're all dancing in and they're carrying the baby. They're all fine. They've all recovered perfectly okay, but it's an operation, right? And the fewer people that I can operate on, honestly and truly, the better. But having said that, we do cesareans all the time, and we don't think twice about it. All right? Yes?
Going back to if the baby's not in an anterior position, are there not things you can do, first of all, like getting on all fours? I understand there's a position you can do that can sort of help stimulate the baby to get in that position, and as well, I'm sure I read something about a chiropractor's manipulation that can help do that as well.
I've never found it useful to put girls up on all fours on their hands and knees. Putting girls up on their having them get up on their hands and knees to see if that will change the position. From my personal experience, I've never found it useful. Sometimes I can put a finger in and help to move the baby. Just grab the baby's head and just push it to see if it'll turn. And sometimes it will, and that'll happen if a girl's got a big pelvis and it's not a first baby. But if it's a first baby and it's stuck in an occiput posterior position, I don't think there's any chiropractor who's going to move the baby. And besides, they're not going to let a chiropractor in the delivery room anyway. Right?
I had read something about, previously that there is a manipulation that they can do to help.
Doesn't work for me.
No.
Doesn't work for me. Usually I'll let you push and I'll try and encourage it to turn, and if it won't, then my option is to turn it with the forceps. Yes? Yes?
I just had one more question.
Yes?
When, say for instance, a piece of a placenta is left inside, the way you can tell the difference, is it just because it's an exorbitant amount of blood? Because you're going to have lochia after for a few
No,
visits.
we look at the placenta. The placenta comes out and we look at it and we say, does it look complete? Okay? And usually it looks complete. You look at it and the placenta looks like it's the whole placenta. Once in a while, there's a piece missing. And you say, okay, where is it? Right? And then you fish it out.
But if you're going to wait for it, say, to come out 2 days later because you can't get it, you can...
With me, that's not likely to happen. If I'm not happy, I'm going in right away and I'm going to make sure that the uterus is empty. It's highly unlikely that I'm going to wait on the placenta. I'm very aggressive and I manage that stage of the delivery. I'll go after the placenta right away. I'm not waiting for 2 days for it to come out. That's not part of my practice.
This is actually going back to the forceps, the tools that you use there.
Yes.
Maybe a foolish question, but how do you actually know, like, is there an ultrasound as you're going in to clamp these things onto the kid? Like, it's like, you're talking about sensitive area and eye.
Absolutely.
Like, that's...
Let me tell you
I look
how...
at that thing and it's like, oh, yeah.
Let me tell you how we do this, okay? It's done by experience. It's done by touch. By feeling the bones on the baby's head, you know where to put the forceps. And you know how they're going to slide on and what it's going to feel like when you've got them on properly. Is it possible to make a mistake? Yeah. If you ask me, have you ever turned a baby that was face down, face up? Turned it back, you turned it the wrong way. The answer is yes. Have I ever done it upside down? Yeah. That girl's got a ton of room. And then when you realize, you just say, I turned it the wrong way, and you turn it back. Have I ever done it? Yes. Have I done it very often? No. When you're doing a forceps operation, let me tell you how I deal with this, okay? And you'll understand. Is there risk? Yes. I try to say to myself, this is my baby. I'm not interested in harming this baby. I want to put the forceps on perfectly. I don't have to be perfect. I just have to be good, okay? I would like to have them on in perfect position. Perfect is great, but good position is acceptable, right? So the first thing that when I'm putting on the forceps on, when I'm doing a forceps rotation is, number one, can I put the forceps on? Can I get them on? Because sometimes it's wedged in so tight, there isn't even room for the forceps, because look, these forceps take up room. That's almost a centimeter. Agreed? Almost a centimeter. I need at least a centimeter of room just to get the forceps on. If it is wedged in so tight that there isn't even a centimeter of room, I'm not even going to get the forceps on. So step number one is, can I get them on? Step number two, can I get them on properly? Am I happy with the position? If they're on perfect, great. If I've got a good application, it's acceptable. Anything less than a good application is unacceptable. So if I'm not sure how good my application is, I'm going to take them off. Because the next thing I'm going to do is I'm going to try to turn the baby. And then I'm going to pull. And I want to know that those forceps are on in good position before I turn the baby or pull. You got it? And the next question people ask is, how hard do you pull? And the answer is, I don't know. I just pull. I'm not out there to pull the baby out at any cost. That is not the game. I'm out there to do this safely. So when I'm pulling, it's usually one hand. And maybe there's a second hand to support the forceps. And maybe I'll just put my foot against the bed so I don't slip, right? But that's it. Just by putting my foot against the bed so I don't move, I'm not pulling any harder, I promise you. I'm not down on the floor and putting 175 pounds of pull on that. That's not happening, okay? I need to do this safely. I need this baby to be delivered in the best possible shape. Now, are there consequences? Sure. Can we leave a mark on the baby? Can we leave a bruise? Yes. Does that happen very often? It happens often enough. I mean, this is stainless steel. The baby is not stainless steel. Is it going to leave a mark? It may very well. Is it going to disappear? Sure. Within a day or two, it's gone. Have I ever cut a baby? Yes. Might get a little cut by the eye. It heals. Have I ever scarred a baby? Never. Never. But bruises? Sure. And sometimes you can get a facial nerve. If your forceps are not on perfectly, you can pick off, you can get a facial paralysis that's temporary, where the baby is. Does that happen? Invariably. It's transient. The forceps have put pressure on the nerve, and the nerve is, to an extent, it's traumatized. And it takes a little time for it to heal. Are these permanent? I've never seen one that's been permanent. Never seen it. But, I mean, are forceps a little bit scary? I don't want to tell you that they're not. This is stainless steel. And you want to push that baby out as best you can. I want this to be a totally and completely uneventful delivery. If we used forceps, it's not an uneventful delivery, right? Something happened, right? You needed some help, and we're going to do what we have to do, right? Remember I said it doesn't always go the way you want it to go. Sometimes it goes the way it has to go, right? You don't always get what you need. You don't always get what you want. You get what you need. And sometimes you need a cesarean or you need a forceps. It's just, right? Am I wrong? It's just the way it is, and you all know this. Yes?
Is it a natural progression when you're using the forceps that the rest of the body is going to turn? Like, how do you guarantee that this...
It turns. It's an amazing thing. We can't, listen, we're not birds. Birds can turn their head around. Humans can't. If you turn the head around so that it's facing that way, you break the neck. Okay? The body turns. And babies, first of all, are much more flexible than we are. So the head has a greater range of motion. We got about this much. We don't have 180 degrees. I can't go 180 this way and 100, right? It's like, you know, where are we, 145, 150? I don't think we're 180. We're for sure not all the way, it's not even that. I mean, it's not 90 each way. If you turn the head around that way, you broke your neck. So the baby, it rotates. And then as soon as we've turned the baby, as soon as the head comes out, it just rotates back. It turns back. Is it if you haven't done it, you haven't seen it, then I can understand that the question you're asking. I can understand the question you're asking. Okay? Yes?
You talked about cesarean after trying to deliver, but what is the process for a scheduled cesarean? When would you tell us, at what week would you tell us we would have to have it?
If I'm going to make an arrangement for a cesarean section for a particular reason, it's going to be done very close to 39 weeks. Okay? I'm not going to let you go to 40 ordinarily because you're probably going to go into labor. And if you go into labor during the daytime, you're going to disrupt the office, you're going to disrupt the operating room, I'm going to have to bump people, it's disruptive. Or you're going to go into labor at 3 o'clock in the morning on Sunday, right? It's going to be the middle of the night. And I'm not going to do it at 38 because even at 38, there's a small risk of respiratory problems. I want to get you as close to 39 weeks as possible. Is 38 okay? Yeah, it is.